matter what the cause is. If a condition is more likely or progresses rapidly due to HIV infection, early heart may be indicated for those with or at high risk for the condition. And we certainly, I think, have hearkened on to this and begun to try to act on it. If a condition is more likely or progresses rapidly due to a specific antiretroviral or class of antiretrovirals, other antiretrovirals or other classes might be indicated. If the condition is independent of HIV or its treatment, conventional approaches to management can be adopted to those with HIV. I would contend to you that that third option is the rarest option, and we need to be very careful about whole cloth adapting primary care guidelines to those with HIV. I think we must tailor them. But what if the condition is associated with all three, which is what I'm contending to you is the rule here, not the exception? HIV infection is a complex chronic disease. Many common non-AIDS conditions are associated with HIV infection and disease progression. AIDS-defining conditions are increasingly rare and variably associated with mortality. How can we assess the total burden of disease and susceptibility of our patients to bad outcome? How can we counsel individuals about where their greatest risk is and what they can do about it? We need a new paradigm to effectively address important causes of morbidity and mortality for those aging with HIV infection. CD4 and viral load are not sufficient. This is a modification of a figure that I used to use for years, which was simply a Venn diagram of 4 circles overlapping. I think we have a little more information now. HIV, viral hepatitis, and substance use clearly drive an awful lot of what we're seeing for our patients with HIV. This is not necessarily the same Venn diagram we would see in another aging population, especially with respect to which substances we're talking about. And certainly viral hepatitis is not nearly as prevalent in the average aging individual as it is in our population, and it has major implications for our management. These 3 conditions interact with each other to cause a whole host of complications for our patients, including immune dysfunction, of which we have biomarkers including CD4 cell count, chronic inflammation and platelet hypercoagulability, which is all the buzz now after the SMART study, and basically suggests that even in people who have undetectable viral load, chronic inflammation continues and has implications for the health and vulnerability of these patients. In addition, people have associated comorbid diseases that they may have had even before they got HIV, like hepatitis C, as well as conditions they're developing as part of the aging and genetic profile they have, or the fact that they're overweight, like hypertension. And treatment toxicity. Toxicity not only from HIV, but from all the other medications they're taking as well. These all interact with each other to lead to incremental depletion in organ system reserve, which again we have biomarkers of. That's things like renal function, liver function, hemoglobin, tests that people send on a routine basis on pretty much every patient, and certainly every HIV patient in care in New York is probably getting these tests on a regular basis. And these in turn lead to the functional decline and organ system failure that Linda was talking about. Now, I would contend to you that not that many of our patients are at this level yet. Most of them are in the sort of pre-frailty or pre-vulnerability point. But the good news about that is if we can pick it up early, we might be able to more effectively prevent their transition into frank organ system failure and frank functional decline. And of course, if people have enough organ system failure and functional decline, they will die more quickly. So I'm going to skip this because Linda already showed you these slides about the frailty phenotype. The point that I would make is that while it is strongly associated with time on heart therapy and it does suggest premature aging among our patients, if you look at the overall proportion of people who have the condition, it's not the norm. It's only about 6% in this sample, and Linda said that when they followed people further out, it got up to about 10 to 15%. So it is something we need to think about, but it's not going to be the standard measure of how we're doing with our patients. Functional status might be more promising. It can be assessed by direct observation or self-report. It ranges from activities of daily living, like walking, to extreme exertion, like running. And it differentiates the risk of mortality, but does not provide pathophysiologic insight into what's driving that risk. So how do we intervene? Is there a more generally applicable approach? Well, I've mentioned that CD4 and viral load are necessary, certainly, but not sufficient. The frailty phenotype is interesting, but relatively uncommon in our patients right now. Functional status is promising, but does not offer causal insight. We need a comprehensive index that does. This is by no means the final word on this subject. It's the first word. We've published recently the Veterans Aging Cohort Risk Index. This is based on a sample of 40,000 veterans in care who have been followed longitudinally for almost a decade. And we have identified that these factors are all independently, after adjustment for each other, associated with mortality risk in our patients, and developed a simple way that you can assign points, much like the Framingham Index does points for the risk of cardiovascular disease. So you'll see that age is important, CD4 count is important, AIDS-defining conditions, viral load, but in addition, anemia is very important. FIB4, which is an estimate of liver injury, is very important. Estimated GFR, which is an estimate of renal function or kidney function, is very important. And ongoing substance use, as well as Hep C and Hep B. This is the association of that point index with mortality. As you can see, it's extremely linear over the entire range of mortality outcomes. So each of these dots represent a group of patients who had that score at baseline. And mortality, as you can see, this is not a truncated graph. I'm showing you all the data here from 0 to 100%. So you can see that people who have very high scores have an extremely high risk of mortality. We're now working on trying to determine whether this score also correlates as strongly with functional status, with quality of life, and with risk of other adverse outcomes like hospitalization or intensive care unit stays. This is survival by the score, broken down over 6 years, grouping people from low scores to high scores. And again, this is not a truncated axis. You can see from 0 to 100%. So what are the implications for an aging epidemic? HIV infection increases risk and progression of common infectious and non-infectious, quote, non-AIDS conditions. And here I'll say, what we know right now shows that there are at least 10 or 15 conditions that are at higher risk among those with HIV. Give us more time and the list will grow. So rather than barrage you with a long list of which conditions they are, since that will get quickly outdated, I think the thing to assume is that until you know that it's not associated, assume that it might be, and ask yourself how that might modify your management. So for instance, intracranial hemorrhage is strongly associated with HIV. We used to think that Topranavir was a major risk for intracranial hemorrhage until we began to look at what the actual rates of intracranial hemorrhage were in people who never saw Topranavir but had HIV. And we began to see that those rates were not that dissimilar from those reported in the Topranavir trial. That's probably not going to be exceptional. Ischemic stroke, hemorrhagic stroke, cardiovascular disease, diabetes, hypertension, to name only a few. Screening and treatment guidelines for non-AIDS conditions must be tailored for those with HIV because in many cases HIV may be a separate risk factor. Some non-AIDS conditions may justify earlier or more aggressive ARV therapy. Well, if in fact these conditions are exacerbated by HIV, maybe those individuals with the condition should be treated earlier. Maybe we should think about treating older individuals earlier since they have less robust immune response. These are all questions that need to be answered. Selected ARV treatments likely cause or exacerbate some non-AIDS conditions like diabetes, but effects are often less pronounced than those of HIV itself. And this bullet is really one that we've only come to appreciate very recently. Yes, HIV treatment has toxicity, and yes, we need to continue to worry about that. But we also need to recognize that a lot of the things that we were calling toxicity previously were actually HIV disease. Finally, we need a more integrated index of clinical indicators to follow our patients' integrated risk of morbidity and mortality and counsel them about those risks and what risks they might be able to most effectively modify to improve their quality of life as well as their survival. I